So here's a video of the Impella CP being placed. I guess my sound's not gonna work. Sorry, guys. So as you've seen that it was just placed over a wire, we take the blood from the left ventricle into our inlet cage. The pump goes across the aortic valve, and then we perfuse through our outlet cage that's sitting in our ascending aorta, and it helps perfuse our end organs. For the 5-5, it is a different approach, like I said. You can either go axillary or directly into the aorta. They completely took out the femoral option for this pump because our goal is to help get this patient's native heart recovered. Plus, the faster they can recover, the better they do. And we know that getting these patients up, walking and moving, they have better outcomes. So, like I said, the 2-step insertion process for the 5-5. This is just a brief video that's just kind of going through there. They got axillary cut down. Wires placed, 5-5s going in. There's a lot of differences that they made from the 5-0 compared to the 5-5 to make it more appealing for physicians to want to place this pump. Taking out the femoral option was one of them. And then taking out the pigtail as well for longer duration of support. So this is our pump that we're probably going to use if we need to be on support even longer, or if we need to unload that patient with more support, such as, getting these patients 6 liters of support. So what kind of patients can benefit from an Impella? I'm just briefly going to go over protected PCI because I know we're here for cardiogenic shock today, but one of our indications is for protected PCI. So what protected PCI is a patient who might not be a candidate for a CABG, or maybe they don't want to get open heart surgery. They now have the option of getting a protected PCI. So what the physician does is they place the Impella before the intervention. Once the Impella is in place, they go in and they do their intervention. They can stent, balloon, atherectomy, get a complete revasc for these patients. It's basically like a CABG on pump, but a PCI on pump, basically, with Impella. So these patients normally have multiple comorbidities. They have complex coronary artery disease, and they have some type of hemodynamic compromise that could potentially cause them to code or rest that in the lab whenever they're getting this doing this intervention. And then the main one that we're going to focus on today is cardiogenic shock. Those are the ones that you guys are going to see in the ICU. So cardiogenic shock, so we see AMI, cardiogenic shock. We see cardiomyopathy and even post-cardiotomy cardiogenic shock patients that benefit from Impella support. And the key with cardiogenic shock is the earlier we can identify cardiogenic shock, the better outcome that they're going to have. So just an overview of some key benefits of protected PCI. It enables us to get heart recovery with getting a complete revasc. We can decrease the amount of times the patient's coming into the hospital to get the procedure done. We improve the EF, and we actually decrease our heart failure classes as well. There's a lower risk for AKI and the need for dialysis, and of course it's a shorter days here in the hospital and less readmission as well. So now going into shock. So shock, basically what Sky did, they broke shock down into 5 classes for us. So this pyramid is the Sky shock classification pyramid. So we go from A through E, what they did here. So A is going to be our patients who are at risk for cardiogenic shock. So those patients may have came in, they're not experiencing any kind of symptoms of cardiogenic shock, but they may have came in with a very large MI. So those patients could potentially go up the spiral into that shock pyramid. B is beginning stages of shock. So those are our patients who we might see who have tachycardia, hypotension, but they're not showing signs of hypoperfusion at this time. So lactic's normal right now. And then we see classic stages of shock. This is a lot of times where physicians might say, this is whenever I'd place an Impella on a patient whenever they're in shock. But really, we want to get them before we get to that hypoperfusion stage. So C is normally whenever we get hypoperfusion at this time. So we know right now we are not getting benefit to those end organs because we are unable to deliver that blood. D is patients that are deteriorating in shock. So basically the treatment method that they're using for that patient is no longer working for that patient. So they might be on inotropes and pressors, and unfortunately it is not helping that patient, so they need to do something else because it's making it worse and going up this pyramid. E is extremis. That's our patients who are probably coming into the hospital with CPR in place. So we know that within this pyramid, Impella can fall within all of these as well with cardiogenic shock. So signs and symptoms of cardiogenic shock. So we're going to see cool, clammy skin because we're unable to give that perfusion to our the largest organ, which is our skin, right? We're going to see anxiety and confusion because we are not giving the brain the blood that it needs because we're unable to push that blood out. We're going to see rapid and shallow breathing. We're also going to see lower than expected blood pressure. So we might see a blood pressure less than 90. There might be inotropes and pressors that are on board and a balloon pump to help maintain that blood pressure. You might see a decrease in your urine output as well, and then you'll see an increase in your lactic that's normally greater than 2. So with, let me go back real fast. So with cardiogenic shock, the traditional treatment options for cardiogenic shock have been for decades inotropes and pressors and balloon pumps. That has been the traditional treatment options. With those traditional treatment options, we have seen survivals in the 50% ranges. You can even see in my bar with the 17%, that was a study that was done in 1973 with the same treatment options that we did in 2017 that showed the same results, or a little bit better, but in the end, it didn't help anything, those inotropes and pressors. And we started to see an increase of survival in cardiogenic shock when we initiated best practice protocols. And some studies that involved that were INNOVA, NCSI, and also JPVAD study as well. So we saw an increase of survival up to 82% with these patients. And what they did in these protocols to call best practice to help get these survival rates up is, first things first, they identified cardiogenic shock as early as they could. They didn't wait. They placed Impella pre-PCI. So like I showed before in that pyramid, we saw A was at beginning. So really we didn't see any signs and symptoms of cardiogenic shock, but we know that they had a massive MI. So we know that they could be going up that spiral, right? Up, down the spiral of cardiogenic shock, but up that pyramid and getting worsened. So they placed it pre-PCI, so maybe that patient that was in A, that they did a protected PCI on basically, before they got into those higher levels of shock, they went ahead and they placed that pre-PCI to hemodynamically stabilize that patient and help recover that heart. So another thing that they did is aggressively titrate inotropes and pressors. So whenever they placed the Impella, as long as the patients were stable enough to titrate those inotropes and pressors, they aggressively did so. Because we know inotropes and pressors can put more workload and more demand on the heart. So increasing that workload and that demand on the heart caused more ischemia in that heart, and we were unable to rest and recover that heart appropriately. And then we identified RV function, and we escalated as soon as we were able to identify if there were any RV dysfunction. They also identified inadequate LV support, and they escalated from there. And then they also made sure that they used a right heart catheter, Swan-Gaines catheter, like Kate talked about in her presentation. I know she showed this slide, but I'm kind of focusing more so on the other parts as well, along with using a Swan-Gaines catheter. So using that Swan catheter, that right heart catheter, it helped identify if the RV was struggling or if the LV was struggling. And we can also use Impella to help determine whether or not if our patients are struggling with the RV and LV as well. And I'll go into that here shortly. And within those survivals of that 71% for that NCSI study, we actually saw a survival to discharge with a native heart recovery greater than 90%. So 90% of those patients were able to go home with their native heart in place, which is great. A lot of times when our patients come in with cardiogenic shock, and unfortunately they have that ischemia to that heart, it doesn't recover, and they're unable to go home then at times to do the things that they like to do, like walking the dog, for instance. They might not be able to go walk their dog anymore without getting short of breath. So another reason why Impella is used is for Impella. So we come in and we unload the left ventricle whenever ECMO is used in place. So we are not there for oxygenation support. That is the ECMO part of it. We help with some end organ perfusion along with the ECMO. We help with the LV unloading, which is going to help with myocardial recovery, which I'll go over here in a few slides. And then we're able to wean these patients off of ECMO even faster and get these patients up walking and moving even sooner. Because we have the Impella in place, we are able to wean the patient off of ECMO, and we know when a patient's on ECMO, they're on bed rest, they can't move. And whenever we're able to get them off and get them up, moving and ambulating, and on just Impella 5.5 support, they have much better native heart recovery. So here's just some videos to show you and some examples of the need for active unloading in cardiogenic shock whenever you have ECMO in place. So ECMO is actually going to increase the afterload, which I'll talk about in the next slide. But this is just a great video to kind of show you that that increased afterload puts that extra demand on that already weak left ventricle that's there. It also creates retrograde perfusion, which can cause LV thrombus to form as well. So what ECMO is doing? So we know ECMO is going to increase our flows, and it's going to increase our mean arterial pressure, which is then in theory going to increase our cardiac power output. We know ECMO has great flows. But what's it doing on the left ventricle side here? So it's increasing our left ventricular end diastolic pressure and our left ventricular end diastolic volume, which most importantly is going to increase that mechanical workload of the heart here and decrease that coronary perfusion by decreasing that O2 supply and increasing that demand, which is not what we want on that sick heart. We want that LV to rest and recover, and using that active unloading with the Impella device with ECMO in combination can help increase that patient's EF long term. So now let's talk about what Impella is doing and the hemodynamics effects of Impella, the benefits of it. This is honestly my favorite slide because it really shows you what Impella is actually doing overall. So we have on the inflow side, which is this side right here, this is going to be in my left ventricle. So that inflow is going to sit in the left ventricle. It pulls blood through that cannula and it comes out of our outlet cage, which is going to be sitting in our ascending aorta. So on that left ventricle, we're decreasing that left ventricular end diastolic volume and pressure. Does anybody here know a normal LV EDP at all? It's about 4 to 12. So normal left ventricular end diastolic pressure is about 4 to 12. Give or take, what book you read. It's like that with any hemodynamics. Anybody guess what a normal LV EDP is probably, or not normal, what an LV EDP is in a cardiogenic shock patient? It's going to be really high, right? Because that heart's unable to squeeze that blood out. So it fills that heart and it fills that LV with a lot of pressure and all that volume that's left in there. So a lot of times we see in cardiogenic shock, we see an increase of our left ventricular end diastolic pressure, and a lot of times it's in the 30s. So that's really high pressure and volume that's being left inside of that ventricle. So Impella comes in, it decreases it, which is going to decrease that wall tension. So whenever we have a high left ventricular end diastolic pressure, it's going to put a lot of workload on that left ventricle, and it's going to basically clamp off all of our microvasculature. So in our heart with our microvasculature, if that pressure is too high, it's not going to help us perfuse our coronary arteries. So if we're not perfusing our coronary arteries, our patients aren't doing so well, right? So whenever that LV EDP is high and we're bringing it down, we're decreasing that wall tension, decreasing that microvasculature resistance, so that way that heart is able to fill, and then increasing that myocardial perfusion, decreasing pulmonary congestion because we're not backing up into the left atrium, which is then going to back up into our lungs. So that's how we're decreasing that pulmonary congestion. And then it's going to increase our O2 supply, but it's going to decrease the demand load on the heart, which is going to decrease the mechanical workload of the heart to allow that heart to rest and recover. And the white here, these are just understudy, what we're working with now with door to unloading. So hopefully you guys hear more about that in the next couple years. And then on our outlet that's sitting in our ascending aorta, that's where we're going to increase our flow, so our cardiac output, and increase our MAP, which is then going to increase our cardiac power output. And I know Kate talked to you guys about cardiac power output, but I just want to bring it up again. It's important for Impella. We monitor our cardiac power output whenever our patients are on Impella to determine whether or not if they're doing well on their current therapy of support, if they need escalation of support, or if they maybe need to be weaned off support and their heart is looking good and it looks like it's recovering well. So cardiac power output is the power and energy of our heart that it takes to perfuse all of our end organs. A normal cardiac power output is going to be 1 to 1.5. That's our normal cardiac power output. 0.6 or less, we see an increase of mortality by 50%. So we don't want to get it to that 0.6 or less, right? We want to make sure that we are above that 0.6 at all times, even higher. Dr. Bill O'Neill, who actually was he was the primary investigator for NCSI, and he developed the protocol that helped him get that survival up to 71%. He says 0.8 must escalate. So if he has an Impella CP in place during his study for national cardiogenic shock, and this is part of his protocol, if the CPO is 0.8, they are going to escalate to an Impella 5.5, especially if that patient's on any kind of inotropes and pressors, because he knows that that heart needs more resting and recovering, and let's wean off of these inotropes and pressors even more. So important to know your cardiac power output to determine whether or not if we need to escalate care for that patient. So now let's go into the Impella devices. Anybody have any questions so far about kind of why we use Impella and the hemodynamics of it? Yes?
Would you go back to that last slide for a second?
Of course.
The microvascular resistance,
Mm-hmm.
is that the same concept that you're getting like in compartment syndrome in your extremities or something? It's just that the heart is so full that it's squishing the myocardium?
Exactly. Yeah.
So the little capillaries in there are
Mm-hmm.
squished flat.
Because all that pressure that's on the heart, yeah, so it's not able to perfuse the heart as well because there's so much pressure and volume that's on that heart. That's why sometimes I like to point out like a normal left ventricular end diastolic pressure and not normal with cardiogenic shock, because you guys might get patients from the cath lab and they might tell you, hey, patient's LV-EDP, we went ahead and got an LV-EDP on this patient. It was 20, and now they're sending them up to the unit. Well, you're thinking back of your head now, that's a high LV-EDP. Why isn't that patient's LV able to empty out more of those contents that are left inside of there? And then is it going to build up and build up because they have a lower EF, and then that's going to push up against all that myocardium, and then unfortunately, all that pressure is going to push up against all that myocardium, and it's going to occlude those vessels that are feeding that heart. So if you have a high LV-EDP and it's causing all that microvasculature resistance to cause on that heart, it's going to kill off that part of that heart, right? There's going to be more ischemia on that heart, unfortunately. Good question, though. Anybody else? All right, let's dive into Impella then. So now the actual Impella device. So I'll start at the most proximal tip, which is going to be my pigtail here. This is the Impella CP with Smart Assist, all right? So this is the one that gets placed femorally in the cath lab, and it is a percutaneous pump. It's 14 French whenever it is placed, and then we taper down to a 13 French whenever we send them off to the ICU. So starting with my pigtail first, that's what's going to sit in my left ventricle, and then my inlet cage is attached to my pigtail, which is going to be pulling blood in my left ventricle through my cannula. You can see where that radial plaque marker is. That is where we can see underneath fluoro where we are related to that aortic valve. And then my outlet area, which is going to be sitting in my ascending aorta, where my blood is going to come out to help perfuse my end organs. And then my motor is behind that outlet, and that's why we're able to be called the world's smallest heart pump, because it is a very tiny motor. And then we have our catheter shaft that goes all the way down into our what we call our repositioning unit, also known as our repo sheath, right here. That's going to sit in the patient's arteriotomy. And then we have our blue suture hub right here. We only suture in the two front proximal eyelets, and I'll tell you why shortly, but take that into consideration. Not all four should really be sutured down on that patient, just the two front ones. And then we have a re-access port here. Why I always like to point out the reaccess port to ICU nurses is because we don't want you guys to be using that reaccess port to get to transduce an art line, to get ABGs. We don't want that because that is sterile. If something happens to that pump, we can actually use that reaccess port to exchange out that pump for another one. So I hope this never happens to you guys, knock on wood. But if an Impella stop ever happened and they had to go exchange out that pump, they can take that patient back to the cath lab and they can basically place a wire down this port right here, remove this old pump, and then place a new pump. Whereas before, when we didn't have that option, we had to take out the old pump. They either had to hold manual pressure, some type of closure device, and then go to the other side, stick it, and then place the new pump. That patient was without support for an extended amount of time that they didn't need to be out of support on. So we don't want you guys to use that. That stylet stays in there. It stays sterile. Plus, I'm not gonna lie, it is very tiny. It only fits an 035 wire. You transducing your art line off of it isn't gonna give you much. And then we have a 2 locking mechanism. This is something that's important to remember for you guys. So the 2 locking mechanism consists of the T-lock, which only job in that is just to bring up the anti-contamination sleeve and lock it to the repositioning sheath. That's the only job. It does not lock down the catheter. What actually locks down the catheter is what we call our TUI Borst valve lock. This lock right here. So if you guys place a pump, or say they place a pump in the middle of the night and they sent you that pump they sent the pump to the unit. And for all my night shift nurses, if you call WASFIA and you're like, WASFIA, we just got this patient in, she's probably gonna be like, all right, I'm gonna come in, I'm gonna come help you guys do this ICU check-in, but first things first is the TUI Borst valve locked, because that is something that is extremely important before we go on, keep treating this patient. We gotta make sure that TUI Borst valve is locked, because if not, that pump is going to migrate and it's gonna cause complications. So always make sure that that's tightened all the way down, all the way to the right. So even communicate that within cath lab whenever you guys get these, before you guys get these patients, just ask them, is the T-lock and is the TUI Borst valve locked? And then we have our anti-contamination sleeve here. The anti-contamination sleeve helps us keep it, it is in the word, so that way if we have to reposition the pump at all, we can actually reposition this pump. And then our red plug, which is basically just the brains behind the operation, it remembers all of our previous alarms and P levels, say if they did have to transfer this patient out. And then our purge sidearm, which is shown right here, has a reservoir on it. It's a little circle part on it, has that reservoir that's gonna hold about 2 to 3 milliliters of fluid. And then also has a micron filter as well to kind of filter out any kind of bacteria or bubbles that might get into that before they get into our pump. And then this is the 5.5. A lot of it is the same purge sidearm, same red plug, anti-contamination sleeve, locking, blue suture hub. But on the actual pump, the main difference is we don't have a pigtail that is attached here. And the reason why we don't have a pigtail is, one, we want this pump to be in for a longer period of time. So we don't want any kind of adhesions to build onto that pigtail that can cause complications later on. Also, we can place this pump directly into the aorta, which makes it easier for us to place it directly into the aorta for those patients who are getting open heart surgery that need support quickly. So now the AIC Council. So let's kind of go over the AIC Council now. So the AIC Council is the interface monitoring for the Impella pump. So it can give us all of our waveforms and numbers that we need to manage this patient on the Impella device. And then it's going to give us our purge solution as well. So it helps us give us our purge to our motor to make sure that our motor is being purged appropriately. And then also it has a backup battery. We want to keep it plugged in, but it does have a backup battery. Say if you guys did have to transport with this patient, it has a battery life of 60 minutes. So just make sure it's always plugged into the wall. And on our AIC, you'll find that there's a roller knob that's on it. So you roll it and you click to select things. And there's also 5 soft key buttons. Now it's deceiving. It looks like it's touchscreen, but it's not. The soft buttons, you touch those, but you can't actually touch the rest of the Impella console and think that it's touchscreen or anything like that. So the 5 soft buttons are going to be mute alarm is going to be the first one. So that's going to just mute our alarms. There's 3 different colors of alarms: red, which is going to be emergent, yellow, which is urgent, and then white, which is just an advisory alarm. And then we go to flow control, which is our second soft key button. Flow control goes from P9 to P0. Now we don't want to go below P2 while we're in the left ventricle, okay? We want to stay above P2 while we're in the LV, and then whenever we go to P1 and P0, that's whenever we're explanting the pump. P levels meaning performance levels. The higher the P level, the more flow that it's going to give that patient, the Impella is going to give for that patient. Display, there's multiple different options that I'll go over. And then there's also purge menu. If you do anything with the purge system at all, you're going to go to purge menu to either change out the purge fluid bag, change out the purge fluid bag in cassette, or to de-air the purge system if needed. If you guys get a chance to do hands-on, maybe have Waspia kind of show you guys how to change out that purge fluid bag. It's really easy. It walks you through step by step, but it's kind of good sometimes just to get a feel for it. And then there's multiple options underneath menu that you'll find, like adjusting your LV placement signal, entering in your cardiac output, and then there's even a repositioning guide there as well, and we'll go over all of that stuff here within this training. So there's multiple options underneath display, like I said. The primary screen that you guys are going to live on about 99.9% of the time is going to be your placement screen. Your placement screen is going to give you your waveforms and your numbers that you're going to use to help treat this patient on the pump. So it's going to help figure out how to treat your patient on your pump. And then your home screen, which is just a pictogram of the heart with the Impella sitting across it, is a great visual for patient and family member education. So that's personally what I would use that for whenever I was at the bedside. I would use that to show my patients, you know, like this is what your husband has in his heart. It's sitting in the left ventricle here, and then it's taking blood into the aorta and perfusing their organs. I will say I would not keep it on that screen, that home screen, because I've done that before as well. And if there's a placement signal unknown alarm, which we'll go over, it'll put a question mark on the heart. And one time I had some lady walk in thinking that her husband was dead because there was a question mark on the heart there. I'm like, no, he's fine, he's fine. It's just, his heart's just a little sick, and the Impella's doing its work, it's okay. So I advise you not to keep it on there. Always make sure you're keeping it on that placement screen. And then we have our infusion history screen down here that's underneath display as well. In that infusion history screen, it's going to give you a breakdown of how much purge solution was actually given to your patient for a given hour. And it's going to break it up between the heparin concentration, the dextrose concentration, and if your patient has bicarb, the bicarb concentration as well. That is what I would use to get your accurate intake of what your Impella is giving your patient. Now there's multiple Kahneman screen elements that I'll go over, but I would use this to determine how much of that purge solution was given to your patient. And then purge screen, which is just a trend of our purge volume and our purge pressure. So now let me go over the placement screen, because this is a screen that you guys will have to know what to do with. So the placement screen is going to give us our AO waveform and our AO numbers that are associated with it. Now we have a sensor that sits directly in the ascending aorta, but we are not a hemodynamic monitoring device. So we cannot educate to say, hey, you can go off of this for your art line. You should have a separate art line for your patient, and that is what you should be titrating your drips off of, not the Impella. Is it going to correlate with the Impella? Most likely, because like I said, there's a sensor that's sitting directly in the aorta, but we want you guys to go off your art line. So with that waveform, we want that to be an aortic waveform, and we want it to mimic our art line blood pressures that are on our monitor as well. And then we have our LV waveforms and our LV numbers. The LV waveform and number is a calculated waveform and number. So it's not going to give us our accurate LV numbers. So that LV number down there, that LV diastolic 2, that's not an accurate LV diastolic number for this patient. This is calculated to help us manage the pump and to help us resolve alarms faster. So there's lots of key benefits to the LV, which is what we added with our Smart Assist technology. So you'll find that your screens on the Impella CP and on the Impella 5.5 placement screen is going to look like this one. They're identical. And then we have our motor current, which is basically the energy between the cannula, between the inlet cage and the outlet cage. So it helps us determine where our position is on our Impella as well. So if there's no longer a gradient difference across the valve, we're not going to see the pulsatility that we see right here. So we always want our motor current to be pulsatile. If it's not pulsatile, it's going to be a flat motor current because there's no longer a gradient difference indicating that the energy between the cannula is either completely in the left ventricle or completely in the aorta. The motor current numbers are going to be based off of your performance level and the pump's function as well. So it's always good to make sure we're watching for trends of our motor current. So do you guys have Epic here, or how do you do? Okay, so I'm sure that's probably where you guys chart your Impella flow sheets as well. In your flow sheets, it's really good to make sure that you are monitoring that motor current to make sure that that's not increasing. Because if that motor current does increase too high and you're noticing a trend up over several hours, then that could potentially be telling you, hey, this might be a motor failure because something is trapped inside of my motor and I'm unable to, and it's causing me higher pressures right now. And then we have common screen elements is what we kind of call it down here. We have Impella flows, which is how much flow is giving our patient. So we can see in the 3.8, that's our mean Impella flow. We do have flows in both systole and diastole. So we work throughout the whole cycle of the heart, so both systole and diastole. So even while the heart's at rest in diastole, we're still getting 3.3 liters of support here with our Impella. And in systole, we're getting 4.3 liters. So that's always kind of nice to look at too, to kind of see what you're getting in both your systolic numbers and diastolic numbers on your Impella device for flows. And then on our purge system, we have purge flow and purge pressure. The purge flow is how much of that purge solution it's anticipating to give that hour. Now, like I said, if you want accurate intake of your purge solution, you're going to go to that infusion history screen that's underneath the display soft button. That's, like I said, it's anticipated. At 11 o'clock, it might say that it's going to give 3 mLs per hour, but 11:05, it might say it's going to give 5 mLs per hour. Purge pressure is how much pressure it's taking the disc that's inside of our purge system to deliver to our patient, into our motor, into our patient. So it detects the pressure that's in there, and at the end of this, you'll kind of get to know what the normal values are for purge pressure and purge volume. And then in the corner there is our cardiac output. So I know Kate has stressed to you the importance of a swan, and you guys really learned about swan management there. With our Impella device, like I said, monitoring that CPO is crucial with these patients to determine whether or not if they need more support, whether it be an Impella 5.5 if they have a CP, or if they need ECMO support as well with that Impella device. So if we have that Swan-Ganz catheter in place, we're going to enter in our cardiac output underneath our menu soft key, and then it's going to automatically calculate our cardiac power output. If it's 0.6 or less, it's going to be highlighted in yellow because, like I said, that's indicating that there's a 50% chance of mortality with that patient, and we need to increase that CPO. Now let's go over our purge system. So why we have that purge fluid that's in our motor is because it creates a barrier. So it's a barrier to our device, and it helps clean our motor bearings. So we know over time when the Impella is in place, it can start to cause, there can be things that can go inside of our motor, like protein buildups, blood, etc., which can cause our motor to fail. So whenever we bring in the purge solution, like it's showing here, it helps protect that motor because if you think about it, the outlet valve is going directly at my motor, perfusing blood at it constantly. 4 liters of support at it at all times. So it just helps create that barrier and to make sure that we are protecting all those motor gaps within there as well. Now the components of the purge system. So one component is going to be the actual purge fluid. So the purge fluid that Abiomed recommends is going to be 25 units per ml of heparin in a D5W bag. We use dextrose with these patients because saline can corrode our motor. So we want to make sure it's D5W, not D5 and normal saline or anything. Another component that we recommend is going to be sodium bicarb in a D5W bag. So the sodium bicarb that we recommend is 25 milliequivalents in a 1 liter D5W bag. I thought somebody had their hand raised, no? Sorry. And then the next component is going to be our purge cassette. So our purge cassette is going to consist of a spike, which is there to spike that bag of your purge solution. And then our cassette, which has that Abiomed logo sitting on there, is going to be sitting inside of our console. It's like kind of like our IV system in the Impella. And then the purge disc, which is down there as well, that's going to detect our purge pressure to determine how much pressure it's taking to deliver that purge system to our motor. So if your patient does have any kind of HIT concerns, that's when we want to make sure that we are using that sodium bicarb. A lot more hospitals are going towards just using a lot of the sodium bicarb rather than the heparin, because what we found is that the heparin really wasn't accounted for in a lot of our patient population. So patients were getting systemic heparin along with, oh no, they were getting systemic heparin along with the heparin from the Impella device. Do you have a chart? There's one in my bag in here. So they were getting both sets of that heparin, and they weren't accounting for the Impella one. So then Abiomed started doing more studies. They said, you know what, let's go ahead and let's try to find something better. So that's whenever we found that sodium bicarb was actually a better option for our motor. So it actually increases the pH even more, which helps clean our motor bearings even better than what it did with the heparin. So that's why a lot of physicians are tending to go more so to the heparin or the sodium bicarb rather than the heparin. Any questions about the heparin in the purge system, or just any about purge at all? No? So within that, we still want to make sure that we are anticoagulating these patients. So Abiomed recommends an ACT goal of 160 to 180 whenever we are managing these patients on support. So we want to make sure we're monitoring that ACT. Some of my hospitals in St. Louis will do it every hour. Some will do it every 3 hours, just kind of depending on where they are. So if they're maybe in like the 150s, they'll go ahead and they'll monitor it every hour to make sure they're in that 160 range. So whatever it is per your guys' protocol. Now let's dive into the ICU check-in. So with the ICU check-in, first things first that we want you guys to do, if the cath lab or the OR hasn't already, we want you to make sure that Abiomed is notified that this pump is in place and they're coming to the unit. So a lot of times the cath lab and the OR will notify the Abiomed team either by calling our 1-800 number, which is our customer support number, or by calling the local rep directly. So that 1-800 number is a 24-hour, 7 days a week team. So say if it's in the middle of the night, and if I have any night shift nurses here, and the cath lab says, no, I haven't even called any of the local team, that might be your best number to call, just so then that way they can get a hold of the local team. So first things first, let's notify them. Second, let's go ahead and make sure that we're ensuring that the angle of entry is maintained. So remember whenever we were going over the Impella CP, and I showed you guys the blue suture hub, and I stressed that we only want the 2 proximal suture hubs sutured down on the patient. That is because we want to make sure we do forward tension sutures in those 2 front eyelets, and then we want to make sure we're matching the angle of that pump. So whenever we insert these pumps in the cath lab, we insert them at a 35 to 40 degree angle. And whenever we dress them, we saw in the past, whenever we were dressing them, we were taping them completely down onto the patient's leg, but we were seeing a lot of groin complications and bleeding at the site. So what we started doing was angle matching our dressing. So we would put a little bit of gauze underneath the Impella. We would take 2 medium-sized tegaderms and cut a V out of each of them and put one on top of the gauze underneath the Impella, and then one right on top of the Impella site right there. So I like to call it my underwear, pants, and shirt when I'm dressing my patient. My underwear is my gauze. My pants and my shirt are my tegaderm. I put my pants and my shirt on. So making sure we're maintaining that angle. We also don't want to hyperextend that angle either, because if we hyperextend it, it's going to tent that arteriotomy and it's going to cause oozing at your groin site. And if we tape it completely down and we're not matching that angle, again, it's going to tent that arteriotomy and it's going to cause oozing. And unfortunately, if you were like me back in the day whenever I was still at bedside, I was putting a sandbag on top of my Impellas thinking I was saving the day. Unfortunately, we did not realize that we were making it worse at that point. So we want to make sure that we're decreasing that bleeding by making sure we're angle matching those Impella sites. We're also going to record the centimeter marking. So behind your TUI bores, that's underneath your anti-contamination sleeve, you'll see that there's a number every 5 and a dash every 1 centimeters. So we're going to record that centimeter marking behind that TUI Borst valve lock. And then we're going to ensure that that TUI Borst valve is locked down completely. We're going to make sure we have good volume status. So we want a goal CVP of 10. That is not me saying that every patient with an Impella needs a CVP of 10. Every patient is going to be a little bit different. Some, grandma who's 90 pounds soaking wet, she's probably not going to need that CVP of 10. If she's cool with a CVP of 6 with no alarms, no hemolysis, no decrease in urine, then that CVP of 6 is her sweet spot. So just kind of monitor it and base it off of your guys' patients. But no, if you guys do have a low CVP and you guys are getting alarms, oh gosh, then we might just need to increase our CVP. Oh, you're fine. And then we also want to record our urinary output and color. My gosh, I got like a tickle in my throat now. Urinary output and color is so important. So we want to make sure that we're perfusing these patients' kidneys appropriately. So that's why the output, of course, is important. But urine color is important because of why, do you guys think? Hemolysis, exactly. So we know that any kind of mechanical coronary support device can eat up red blood cells, which can cause hemolysis. We know that the Impella can cause hemolysis at times, and I'll go over ways to prevent that. So we want to make sure we're not seeing any kind of pink or red or maroon tinged urine. Whenever we see those, that's whenever we're concerned that there's something going wrong with the Impella, either the preload's low or our positioning is wrong. So we want to make sure we're watching that urinary output. If you ever see any kind of pink or red urine, notify the physician immediately. Personally, me as a clinical in St. Louis, I like to be notified as well. Thank you, Wespia. Can I put it down right here? Okay. I like to be notified as well, so in that way I can come on site just to kind of help out that complication. And then we want to get a baseline echo. So whenever we are in the cath lab, we place these pumps underneath fluoroscopy. Fluoroscopy is great, but unfortunately we cannot see where we are related to cardiac structures. So we want to make sure that the Impella is free floating in the left ventricular space. We also want to get a measurement from the inlet cage back to the aortic valve, and we want to make sure that's appropriate. Our goal is 3.5 centimeters from that inlet cage back to the aortic valve annulus. Again, just like the CVP, not every patient's going to have that perfect 3.5 centimeters from the inlet to the aortic valve annulus. It might be a little bit different on somebody. And even if somebody has that perfect 3.5 centimeters, but you guys have hemolysis, we probably just need to reposition that pump for that patient because it could be causing that hemolysis. Also, another thing that you're going to do is switch out the purge solution. So in the OR, if they're placing an Impella 5.5, we recommend for those pumps to be started with either heparin or bicarb to start off with. But in the cath lab, a lot of times these pumps are placed emergently, and they just place the pump with D5W, and they send the patients off to the unit with D5W in place. So we want to make sure whenever they get to the cath lab that you guys are switching out that purge solution, so that way we are maintaining our motor appropriately to clear out those motor gaps with the appropriate purge solution. So you'll either switch it out to that sodium bicarb or that heparin concentration. It's all determined on the patient and the physician that they're what they pick. So just looking at some kind of ICU groin management for our Impella CP device, whenever you have a CP device in place, we want to make sure that we are not leaving the peel away sheath in place, which a lot of times most physicians do not leave them in place just because the peel away is designed to pop and peel away. And if that is sitting in your artery, if you imagine if that started peeling away and you weren't watching that patient's groin at all times, the patient could start to bleed out at that time. So they normally tend to not leave them in. They also leave a lot of dead space, which can lead to thrombus being formed and being traveled down the patient's leg. Another thing we want to take into consideration for femorally placed pumps as well is to make sure that there's a knee mobilizer in place. We don't want those patients kicking their legs up and down, and then that can cause slack to migrate into the heart. We know whenever our femoral place pump is in place, there is a tendency for it to migrate a little bit more than what our 5.5 is. And the reasoning for that is there's a lot more clearance here. There's a lot more space and a lot more slack that can build up inside of our aorta whenever we have it placed femorally, and it can dive deeper or kind of move back even faster. 5.5, you don't really see positioning issues quite as often because there's not as much slack that's built up. And then also making sure we have those forward tension sutures in place for the Impella CP whenever it's placed femorally. And then for our ACT, that's for all of our Impella heart pumps. We want that ACT goal of 160 to 180. And then just making sure we're watching that groin site to make sure that there's not any kind of complications such as a hematoma, hypotension, tachycardia, signs and symptoms that maybe this patient has some type of complication at the groin site. It is a large bore device, so take that into consideration whenever it is an Impella CP, that we want to make sure that we are watching that groin site for any kind of complications, but also making sure that we're looking for our distal limb perfusion as well. So every hour we should be checking those that distal perfusion. So now let's go into managing these pumps and alarms. So number one, Impella is preload dependent. If we don't have blood in that left ventricle, we are not going to be able to help perfuse that patient as well with the Impella. And we're going to run into what we call suction alarms. There's multiple reasons why patients with an Impella have low preload. They're really sick patients a lot of times. And as we saw in that pyramid, we saw that E stage. We see a lot of Impella patients in that E stage, unfortunately. And with that E stage, we know how sick they are. We know that they probably are going to get dialysis. They might be on ECMO support, things like that, where it's going to decrease our preload. So our goal CVP is going to be 10. We want to make sure we have adequate preload, because if not, we're going to run into suction alarms, which can lead to hemolysis, and it leads to us not giving a full benefit to our patient as well. So what is a suction alarm? Basically, a suction alarm is whenever it is sucking up against something and it's not able to give us adequate amount of flows. So there's 3 reasons why we might get a suction alarm. One is going to be inadequate flow or inadequate volume in the LV, so just low preload. Another one's going to be inadequate position within the Impella. And then the third one is going to be right heart failure. So those are 3 reasons why we might get a suction alarm. First things first, whenever we do get a suction alarm, we're going to decrease the P level 1 to 2 P levels at a time until we break the suction. So you're going to see that yellow suction alarm come up. You're going to decrease it 1 to 2 P levels at a time. And then that yellow suction alarm is going to clear out and it's going to go gray and it's going to say alarm resolved. That's whenever we know suction has been cleared. Whenever we have a suction alarm, it can lead to hemolysis, and our patients aren't getting the full benefit of support as well. So we want to make sure we're treating these suction alarms as fast as we can. And one thing that Abiomed did whenever they came up with the Smart Assist technology, they were like, we want to make sure that whenever the staff gets any kind of suction alarm on the Impella device, they know what's going on with the Impella. So they came out with that LV tracing to help us determine what the cause is really of our suction alarm. So we use the LV numbers to help determine kind of why we might have this suction alarm. So on my first one here is my diastolic suction. So like I said before, the LV waveform and the LV numbers are calculated LV waveform and number. So on an Impella device, an LV diastolic number is going to range anywhere between a positive 10 number to even like a negative 15 number. And that can be normal on an Impella LV diastolic number. Now, if we start to see that LV number is trending more and more negative, and we're getting extremely negative at the end of diastole, we know that we could be running into a suction alarm. And then all of a sudden now you get a suction alarm, and you see what your waveform and your numbers look like in this top one. So I see that my LV diastolic is extremely negative, but my LV systolic number still looks good. Our LV systolic number should be about 10 or 20 or maybe even spot on of our AO systolic number, just kind of basically depending on the patient's aortic valve. But right now I'm like, okay, that looks good. My AO systolic number looks good, but why is my LV diastolic number extremely negative? And why am I getting this suction alarm? Another thing we can look at whenever we get a suction alarm and our LV numbers look like that is looking at our LV waveform. So you can see that diacritic notch where it has 1 at, you can see that that diacritic notch is there, indicating that it's taking me longer to recover at the end of diastole, but I still recover into systole where we see in 2, and giving me my 138 LV systolic number. Another thing that I can look at when I get this diastolic suction alarm is looking at my Impella flows. So my max systolic flows still look good, but my diastolic flows are lower than expected. So again, it's showing me that it's taking me longer to recover at the end of diastole. So with that being said, with a diastolic suction alarms, it can be 2 things. So in the beginning of suction alarms, I said suction alarm can be caused by 3 things. The first diastolic suction one can be caused by 2 of those 3 things. So 1, it can be low preload in the left ventricle, right? So we just don't have enough volume in that left ventricle, which is why it's taking me so long to recover at the end of diastole, and that is why I'm sucking down. Or it could also be right heart failure. So my RV is not kicking over enough volume to my left side because it cannot keep up with it, and my RV is failing, indicating that I got a suction alarm related to RV failure. So at one point I did say in the beginning of this lecture, I was talking about how Impella can help us identify right heart failure faster. So that is one reason why. Number 1, we're always going to have a swan in our Impella patients. That is always our goal with an Impella patient, always have a PA catheter. Number 2, if we have a suction and we're getting all these suction alarms, it could be that we just have right heart failure. So whenever I get a diastolic suction alarm, there's one thing that I'm really going to look at, and it's going to be my CVP. I'm going to look at my CVP. If my CVP is 5, what do you guys think is the issue? Volume. But what if my CVP is 20? It could be right heart failure, right? Because where our CVP is measured in our right atrium, right? And if when our CVP is measured in our right atrium and that right atrium pressures are increasing, that's because that left side cannot squeeze it over into our left and it's backing up into our right, causing all that JVD, causing us to have suction alarms because we don't have enough volume on that side. So at that point, now I know how to treat my patient. I'll look at my CVP, I'll decrease my P levels to break that suction to decrease the risk on that patient. But now looking at my continuous suction. So whenever you guys get a suction alarm, it's not going to say in the little yellow box diastolic suction or continuous suction. It's just going to say suction. So whenever you get a continuous suction alarm, this is what it's going to look like. So basically, it's going to take you longer to recover at the end of diastole, but we're not going to recover into systole at that time. So now you notice that both my diastolic flows are extremely negative, but also my LV systolic numbers are also really lower than expected. And then also now looking at the waveform, my waveform looks a lot different than what it should look like. And it even looks a lot different than what it should look like with a diastolic suction alarm. They've now have separated away from each other and now they're decoupling. So that's also an indicator that this is a suction alarm related to positioning. Another thing is going to be my Impella flows that I can look at. Now in my Impella flows, I have lower flows than expected in both systole and diastole at that P level. So whenever we get a suction alarm that's related, that looks like continuous suction, we're going to then make sure we first break the suction because we want to decrease any kind of harm to that patient. And whenever we break that suction, most of the time, actually almost all the time, we get increased flows on our Impella device as well versus whenever we had that suction event. So we're going to decrease that suction alarm at that time by decreasing 1 to 2 P levels, and then we're going to call the provider, make sure they can put in for a stat echo because we need to get this pump repositioned immediately. Now, whenever now whenever I get a suction alarm that's related to positioning alarms, it's not saying that I'm completely in the left ventricle or completely in the aorta. So you're still going to have a pulsatile motor current. It's just meaning that maybe I'm 1 or 2 centimeters too deep or too shallow. And it's a great thing that that suction alarm is there to kind of notify you whenever it's out of position, because we don't want it to get to the point where it starts to cause hemolysis and that breakage of that red blood cells. So like going back to this slide here, and I want you guys to see this suction alarm, because also, whenever you get a suction alarm, anytime you get an alarm with an Impella, the great thing is it's going to tell you what to do basically. So right here it's telling me, first, reduce your Impella P levels. Number 2, it's going to say check filling and volume status. That's going to be the first one that it says to check, even if it looks like continuous suction, because that's the easiest one to kind of check off. And then number 3 thing it's going to say is to check Impella position. But we know, looking at our LV waveforms, which one we should look at first, right? So it's just going to tell you just suction. You're welcome. And like I said, there's 3 reasons why we'll get those suction alarms: inadequate volume in the LV, right heart failure, or incorrect position in the left ventricle. All right, so just briefly to tell you guys, Impella is also afterload sensitive. If our SVR is high, if our MAP is high, we cannot work against all of that resistance in the heart. So our heart, or our pump, is going to be trying to work up against all of this resistance in the left ventricle, and it's going to cause us to have decreased flows because of all of that high resistance that's in there. So our MAP goal on the Impella is going to be about 60 to 80. Now I know normally your guys' MAP goals, probably when you guys are taking care of patients, are 65. Do whatever your guys' MAP goal is for you guys. But we don't want it really too far above that 80 mark, or especially that 90 mark. We don't really want it that much higher, because it's going to decrease our Impella flows, and it's going to cause more workload on that heart then. So if you are on inotropes and pressors, then would be the time to really make sure that we are decreasing those when we have that higher MAP, or SVR if you guys are monitoring your SVR. So positioning is crucial whenever it comes to Impella. If we are in the incorrect position, we are going to cause damage to that patient, which could cause hemolysis. And if we have hemolysis that is happening for a longer period of time, it is unfortunately going to break down those red blood cells, which is going to cause kidney failure and liver failure as well. So that is not something that we want. So that's why it's a great thing that we have alarms in place to help us kind of diagnose that stuff before it gets to hemolysis, but also why we take into consideration things like getting an echo whenever we get an ICU check-in, or getting echoes frequently, maybe whenever we start to notice something with our Impella device. So getting an echo is really important to monitor the position. Position alarms that you're going to see on the Impella are going to be Impella position in the aorta. Now, if we are completely in the aorta, things that you're going to note on the placement screen. So you'll note that both my LV waveform and my AO waveform are now both aortic waveforms. And you'll also notice that my AO numbers and my LV numbers are now both aortic numbers. I hope my LV number is not 56. That's a really high LV diastolic number for an Impella. So seeing that right there already just in those top waveforms, I already know that this is probably completely in the aorta. But then I get it confirmed that, hey, my motor current's flat, indicating that there's no longer a gradient difference across that valve, causing that pulsatility. So we are no longer across that valve appropriately. And then I see my alarm. So your alarm's going to pop up as soon as it dictates all of these waveforms and numbers. So my alarm is telling me exactly what to do. It's telling me your Impella position's in your aorta. I don't even need that alarm though now, because now you guys know waveforms, so you guys don't even need them. But it's still there for you. And it's going to tell you exactly what to do with this pump. It's going to say, first things first, decrease the Impella down to P2. So we're going to take it down to P2. Next thing it's going to tell you to do is reposition the pump with imaging. So we're going to notify the physician, let them know that the Impella is completely in the aorta, and we're going to get a stat echo for that patient. We're going to get a stat echo, and then the physician's going to come in and reposition that device underneath echo guidance. And the reasoning why we want to get it repositioned underneath echo guidance is because we want to make sure we're visualizing that valve opening and then getting that Impella across appropriately. versus not doing it underneath echo guidance. You're just trying to shove an Impella in, which could damage the valve or damage the pump, or both. So we want to make sure we're getting an echo for that patient. And then once it's in the correct position and back across that valve, that's whenever we're going to go back up on our P level, about 2 P levels about every 30 seconds. So we're going to go ahead and just keep going up on that. The other Impella position wrong alarm is going to be Impella position and ventricle. So there's 2 places really it's going to go completely into, either completely in the ventricle or completely in the aorta. Looking at my waveforms though, both of my aortic and my left ventricular waveforms are now both ventricular waveforms. And looking at my AO and my LV numbers, those are more left ventricular numbers now. So looking at my AO diastolic number, that looks more like an LV diastolic number, doesn't it? That does not look like an AO diastolic number. I hope that that patient's AO diastolic is not 12. Now looking at my motor current. My motor current is now flat, it's not pulsatile. So now I know for sure I no longer have that gradient difference across the valve. My Impellas tell me exactly where I'm at. Impella position and ventricle. This is different though. When we're in the aorta, we reposition underneath echo guidance. Whenever we're completely in the ventricle, we're actually going to reposition the pump underneath Impella guidance. So we're going to decrease it down to P2, and then at that time, we're going to go to the menu soft key, and we're going to press repositioning guide and have the physician reposition the pump using our Impella guidance. So here's just a short little video kind of showing you that. Again, the sound's not working, unfortunately, but I'll walk you through. So basically what this is showing you, it's showing you how to reposition this pump with that repositioning guide. That repositioning guide is only going to show up whenever we are completely in the ventricle. So if you're not completely in the ventricle, it's going to be grayed out at all times. So you can do this with the Smart Assist technology, so the CP and the 5.5, and what they're going to do is they're going to go to that menu soft key options. They're going to get that alarm. Hold on. So right here, she gets that alarm. They're decreasing it down to P2. After they've decreased it down to P2, now they're going to go into that menu option. And once they go into that menu option, they're going to go into the repositioning guide. Physician is going to be there at the patient's side, like either groin side or above if it's a 5.5. The physician's going to loosen that Tuohy-Borst valve lock while you guys are monitoring the console. They're going to pull back 1 centimeter at a time until they get an aortic tracing on the console. So you'll see here in just a second. Now they got that aortic tracing on the console. You're going to press done. And then the physician's going to pull back an extra 3 more centimeters. So the reason why we have to pull back that additional 3 more centimeters is because whenever our Impella goes completely in the ventricle, our motor, our sensor is right there on our outlet cage. So as soon as we pull it back enough to go into the aorta, it's immediately going to give us that aortic tracing. But our outlet cage is still going to be way too close to that aortic valve, which is going to cause a destruction of those red blood cells. So that's why it is extremely important to always make sure that they are still pulling back the additional 3 more centimeters to make sure that we get it in the proper position. After it is in proper position that way, we're going to make sure that we go up on our P levels, 2 P levels at a time, about every 30 seconds, all right? And it'll tell you to do that as well during that. Now, still important to get an echo after that. It doesn't have to be right away. It's something that can kind of wait because we know that the patient's getting benefit from the Impella. So the key benefit of having that repositioning guide is to getting these patients back on proper support faster. Whereas if it's completely in the aorta, we're kind of waiting for a lot of parties here in order to get that patient, to get that pump back into a correct position. Another position-related issue that you might see is placement signal low alarm. This is an alarm that you might not see too often, but it can happen. Placement signal low is basically it's gonna trigger that alarm whenever our AO diastolic number is less than 30. So with that being said, Placement signal low can mean two different things. It can mean that my pump is too deep and my sensor is too close to my ventricle, and then that means my outlet cage is right on top of my aortic valve, and that's going to cause tons of hemolysis, unfortunately. Or it can also mean the patient's hemodynamics and the patient's arterial blood pressure is literally a diastolic of 30. So check, first things first, check your hemodynamics, check your blood pressure. Is your blood pressure really less than 30 in the diastolic? If it is, that's the cause. Maybe they need some drips probably at that point or something else. But if it is a position-related issue, say that basically your blood pressure is on the monitor 120/80, but you're still getting this alarm here that's showing that LV or that AO diastolic low, then that's a position-related issue. We need to call the physician, get an echo, and get this pump back in the correct spot. Now, Impella position unknown. This isn't a position-related issue, but I do want to put that in this kind of part of this slide deck. Impella position unknown is low native heart pulsatility. So it's just saying that the position's unknown because the pulse pressure difference is extremely narrow, which is well, we see it here, our pulse pressure is extremely narrow, but we also see that my AO waveform is a lot more diminished than what it should be. So my AO waveform doesn't have that great pulsatile aortic waveform. With an Impella in place, it can be normal to have that decrossed pulsatility, especially with the Impella 5.5. What's a normal cardiac output? Huh? 2 to 8, yeah, I mean, well, it kind of varies. So I like to kind of say 4 to 8. I mean, 8 if you're like Shaquille O'Neal and like you need all that extra, all that extra support. But really a true, honest, true cardiac output is going to be more around like the 4 to 6 range. The Impella CP is going to give you 4.3 liters of support. The Impella 5.5 is going to give you 6.3 liters of support. So we are literally doing all the workload of that heart, which is okay because in the end, in the grand scheme of things, what do we want to do? We want to recover this heart. We want to rest this heart and recover this heart. And resting and recovering that heart means that we're taking that workload away from that heart, giving that heart a little vacation, and then letting that heart wake up on its own and recover all of that ischemia that could have happened. So this is something that can be common with an Impella. If you get that Impella position unknown alarm, it is literally just telling you that the Impella position is unknown due to low native pulsatility and just to watch the patient's hemodynamics. That's all you have to do at that point is just watch those patients' hemodynamics. It is going to have that white advisory alarm just letting you know, basically saying like this patient's pretty sick right now, it's got a pretty sick heart, just keep a real close eye. This is just more about positioning. Make sure that whenever we have an Impella patient, 2 Eboris valves locked, knee mobilizers in place, just those are some things that we want to make sure so that way we're not getting out of position. Another thing to take into consideration, who's night shift here? Anybody? All right, we got some, good. The 3 a.m. life-saving baths on my Impella patient, get those closer to the morning. So if you can, push those baths for our Impella patients closer to like the 6 a.m. range. I know it's later in your guys' shift, but then that way you guys know there's so many more resources that you guys are gonna get that are about to come on for day shift, rather than doing it at 3 o'clock in the morning and having to call the cardiologist to come and reposition that pump at that time. So that's my recommendation for baths on these patients. If you do have to do them at night, put them closer to the morning time. So looking at the Impella underneath echo, do we have any nurse practitioners or echo techs or anything in here? NPs, APPs, no? Echo techs? Awesome. So looking at the Impella underneath echo, we like to look at the landmarks of the Impella. So first we like to point out the Impella cannula, which looks like railroad tracks on the Impella device, looks like railroad tracks underneath echo. And then we have our inlet cage. Our inlet cage right here kind of shows like a black shadow on Impella, or on echo. And then our teardrop, which a lot of times you can actually see the teardrop on echo, and it's something to really help identify the teardrop and where the inlet cage is, because that inlet cage can be like that black shadow. And then that pigtail cannula right there, that pigtail can be a little hard to see at times, and most times you can't see it, sometimes you can underneath echo. So here's what the Impella looks like on echo, well, and then the Impella comes up. So you can see that cannula right there, those railroad tracks, up to that kind of that black mosaic area where we see that's the inlet cage. And then we see the teardrop. So that top one that they showed for the 3.5 centimeters, that 3.5 centimeters is a measurement from that inlet cage back to my aortic valve annulus. And then that 4 centimeters is showing you basically from my teardrop back to my aortic valve annulus. So if you're measuring from the teardrop back to that aortic valve annulus, it is going to be, of course, a little bit deeper, and it's going to range between that 4 centimeters. Like I said, every patient's going to be a little bit different. Not every patient's going to have that perfect 3.5 centimeters for our Impella positioning. Here's just an abnormal echo with Impella, so you can see that we're trapped in here in that papillary muscle and that we are way too deep with our Impella device. That's going to cause a lot of issues. One, that impatient's not going to be supported as appropriately, and then 2, we're going to cause quite a bit of hemolysis that way as well. And if, say, the physician, you guys are all kind of in the echo techs are kind of questioning whether or not if the pump is maybe a little too deep, sometimes what they can do is throw a little color on the Doppler to verify that it is in the correct position. If the color, mosaic color, goes up into the aortic valve, we know we have good position on the Impella because the outlet cage is above the valve. If we see that mosaic color going underneath the valve, that's whenever we know that it could be a little bit too deep at that point because it's having flows going down into the left ventricle. And then so that's with the CP. With the 5.5, we do measure it deeper. So we actually measure at 5 centimeters versus the 3.5 centimeters. So that one does range a little bit deeper into our patients rather than the Impella CP does. And the recommended view for those are going to be parasternal long axis views whenever we do have a TTE. All right, so hemolysis. If we do suspect hemolysis, like I said, notify the physician immediately. So they might want to run some tests on that patient to determine whether or not if it is true hemolysis. If the patient just got an Impella and then a couple hours later the patient's urine start to look pink, I would personally say let's blame the Impella device, let's get an echo, let's check preload right there. Just so that way we can kind of nip it in the bud as soon as we can. And then escalation of care. So making sure that we're monitoring the need for escalation of care is important. So whether or not if we need an Impella 5.5 if we have a CP in place, or if we need ECMO support as well with our Impella, we're going to make sure that we're watching those things. So we want to make sure that we're watching for trends in our patients. So we want to make sure we're watching the trend of our cardiac output, cardiac power output, our urine, also our lactic level is going to give us a lot of information as well. If our lactic keeps increasing, we're not perfusing that patient like we should, causing that lactic to increase. And then if the patient is inotrope or pressor dependent. So if they are requiring quite a bit of inotropes and pressors and they're still kind of on that fence, maybe we need to just go ahead and escalate up. So then that way we're not putting more workload on that heart. Because we know inotropes and pressors, they increase that O2 demand on that heart, making it work harder, not allowing that heart to truly rest and recover like it can with an Impella device. All right, so using Impella with ECMO. So I went over, there's a lot of different benefits of using Impella and ECMO in combination, especially when we have VA ECMO in place. It puts a lot of workload on that left ventricle and it decreases that patient's EF, whereas when we put the Impella in place, it decreases that afterload that it's putting on that heart and actually improves their left ventricle EF. So whenever you do have them in combination, we're going to make sure that we are managing our P levels appropriately. So whenever they are in combination, we want to make sure we know that the ECMO device is the primary support for that patient until we start to wean it, and then we're starting to make the Impella the primary device. So in the beginning, the ECMO is going to be the primary support device for that patient. So with that being said, we don't want higher P levels because we're going to fight for volume within that pump. So initially, whenever they first place the Impella with ECMO, it's probably going to range at P4. So they're probably going to start at P4. So like I said, P9 is our highest P level. So we're going to already start off at a lower P level. And the reason why we start at P4 probably is because we have all that extra volume that's sitting in our left ventricle from all that afterload that the VA ECMO has already placed on that patient. So it's going to be at that P4. But after maybe a day has gone by, even maybe 12 hours have gone by, we'll probably have to decrease that P level even more. So we'll probably have to decrease it down to P2 or P3 or even P2. I've even seen we had to decrease it down to P1. Remember, we are just there to just unload a little bit. So we don't need the full unloading support like how we normally can with an Impella with 4.3 or 6.3 liters of support. We just need some minorly unloading until we become that primary support device. If we're at that higher P level, number one, we're going to cause suction alarms at that time. We don't want that. And it could cause increase of hemolysis then as well. So keeping it, like I said, it'll start at P4, and then after that initial kind of decrease of that pressure in our left ventricle, we'll turn it down probably another 1 or 2 P levels, sometimes all the way down to P1. Did that answer your question okay? Awesome. So adjusting the LV placement signal, this alarm is just a white advisory alarm. It's nothing that you have to do right away, but this is just letting you know that it just needs to be recalibrated, and this is normally about 24 hours after the pump is in place. So you'll just go to menu soft key option like they showed here, go to adjust LV weight, go to adjust LV signal, whatever the suggested LV number is, it should already be adjusted to it, and you just press done. That's all you have to do. It'll notify you if it needs an LV adjustment. And then to enter in your cardiac output, you're going to go to the menu soft key option, enter cardiac output, whatever your cardiac output is, you'll enter it using the roller knob and then select done, and it'll automatically calculate that cardiac power output. Now it will give you a white advisory alarm to tell you to re-enter a new cardiac output at 7 hours. If you guys no longer have a source to that cardiac output, not a big deal. It'll just turn into dashes at that time. But if you still do have your cardiac a way to enter in your cardiac output, we still want you guys to be entering that, because that's going to help us with, again, determine whether or not if our patient needs more support or if we need to go down on support potentially. Maybe they're ready to be weaned off of support. Purge pressure low. So like I said, your purge pressure and your purge system, you can have alarms like purge pressure low and purge pressure high. So if the purge pressure is too low, you're going to notice your purge pressure is less than 300, and your purge flows are going to be greater than 30 milliliters per hour. With those, you are going to first check for any kind of loose connections. So check for any kind of loose connections within the system, and then check for any kind of leaking. Sometimes you might have to replace the purge cassette if needed, but those are the first things that we're going to check off with purge pressure low. Purge pressure high, we're going to see flows, those purge flows less than 2, and then we're going to see a greater purge pressure of 1100 or greater. With those, we're just going to kind of check to make sure that nothing's rolled over on our purge tubing. It is very long purge tubing. So sometimes it gets caught in a bed rail, sometimes it gets caught underneath a wheel, and then you just have to make sure that that's not causing that increase in pressure, that kinking. So check for any kind of kinking first. CPR, if you guys do have to initiate CPR on this patient, of course initiate it per your hospital protocol. Once you guys have initiated that CPR, make sure when the next person comes into the room, they turn the Impella down to P2. Once ROSC is achieved, that's whenever we're going to go ahead and make sure that we get an echo to make sure that we're still in the correct position. If you do have to shock the patient for any reason, no need to do anything with the Impella, no need to even get an echo afterwards. We're just going to make sure that we don't touch the Impella console or the Impella tubing. Weaning and explaning with the Impella left-sided devices, we do have a trend screen to help us wean our patients off support faster. So this is our LV EDP trend screen, and this is found underneath the display soft key option. With this, you'll see that we have a mean AO pressure, we have an LV EDP trend, and then we also have our cardiac output that we've placed in here. And we can see what our Impella flows are versus our native heart with our cardiac output. So it kind of can tell us whether or not if our patient is ready to come off of support. So whenever we do have a patient that might be able to be weaned off support, we want to see that native heart waking up and those Impella flows are going down. We don't really want to see that native heart going down because we know that that heart is not ready to come off that support yet. So I like to say whenever I'm weaning my patients off support, it's like me coming home from vacation. Sometimes I'm not quite ready to get back in the swing of things, so I'm going to slowly wean myself back in, and then I'm going to try, But we don't want to kind of rush it too quickly, so we'll decrease the P levels pretty slowly, monitor our LV-EDP trend screen to make sure that we're not weaning that patient too fast. The heart sometimes just likes to stay at the beach, it likes to stay on vacation a little extra longer. And then with weaning and explaning, it looks a little different between the 5.5 and the CP. So with the 5.5 device, of course, that wean is going to be longer than the Impella CP because A, it's giving you more flows, and B, typically the 5.5s are in the patient a lot longer. So first things first, whenever we're weaning these patients off support, we want to be off our minimized inotropes and pressors first. So we want to make sure we have that covered. And then whenever we're weaning support, we're weaning by 2 P levels at a time, as long as the patient's hemodynamics can tolerate it. After that, then we're going to make sure if our patients are able to be weaned, they'll probably take this patient back to the OR if it is a 5.5, because they're going to surgically close that site. But if it's the CP, they might do it at bedside, and they're going to remove it. They're going to remove the CP across the valve at P1. And then at P0, they're going to remove the device completely out and pull that white connector cable. This is a great just kind of overview. I don't know if anybody wants to take a picture, or if you guys have this already. It just is a little overview of kind of our alarms that you might see, kind of what to do, and some recommendations on our purge pressure, purge flow solution, and our ACT that we recommend as well. Okay, so now let's talk about the Impella RP. So our RP is our right-sided heart device. So I'm just going to briefly go over RP. I don't know if it's going to even work there. RP, you might not see quite as often as what you are with the left-sided devices. So of course, it's a percutaneous venous approach that we're going to use. It goes up to that IVC, right atrium, tricuspid valve, into the left ventricle, up to that pulmonic valve, and it sits in the pulmonary artery. It takes blood from our IVC, where our inlet cage is sitting, and it takes blood out of our IVC into our PA, where our outlet cage is sitting in our PA. And it bypasses the RV to allow that RV to rest and recover. And it enables hemodynamic support. It provides us 4 liters of support. Like I said before, you might see a bipella in a patient. So you might see a left-sided device and a right-sided device all in one. So things to consider first is we're going to watch for monitoring our patient for any kind of right heart failure. So things that we're going to watch for is a reduction of flows from the Impella device and our suction alarms. So like I said, those diastolic suction alarms can help us indicate right heart failure even faster. We're going to see an elevated of our CVP. We're also going to see signs and symptoms of liver failure, and then also a reduction in our PAPI score, like Kate talked about today. And then things that we're going to do is get the patient supported as soon as possible. So the sooner that we can treat RV failure, the better the outcomes that we have. We know if we wait for patients that are in RV failure for greater than 48 hours, they're most likely not, unfortunately, going to make it out of the hospital with RV failure that's prolonged greater than 48 hours. So the earlier we can identify it, the better outcome that they're going to have. So then what Impella is doing, I kind of talked about in the video, but in our inflow side that's sitting in our IVC, that's where we're going to decrease that CVP and that right ventricular pressure as well, decrease those RV wall motion tension, decrease the RV workload, and decrease that O2 demand. And then on the outflow side that's sitting in that pulmonary artery, that's when we're going to increase the flow to the PEA, which is going to increase LV preload and increase cardiac output, which can increase our cardiac power output. So I will note that sometimes after they've placed an Impella, we do identify that this patient may have had mild RV function prior to placing Impella, and sometimes after an LVAD is placed, especially a bigger LVAD like a 5.5, it does tend to show that the RV was failing more than what we thought it was. because now we've increased that flow to the left side and the RV can't keep up, and it was like, wait a second, I'm actually a lot sicker than what I really was. I'm not used to keeping up with this amount of flow for you. So take that into consideration. If you do have a 5.5, really make sure that you're looking for those signs and symptoms of that right heart failure. Our P pump, of course, the shape is totally different. You'll see that the blue suture, or the blue hub is different than our red hub, indicating that that's a venous pump versus an arterial pump. The purge sidearm is the same. We do still have the same locking mechanisms as well, the T-lock and the 2E Borst valve lock. And of course, the shape on the actual Impella catheter is different as well, where our inlet cage is sitting in our IVC there, and then our outlet is sitting in that PA. Placement screen. So on our placement screen here, we're actually going to have PA waveforms and PA numbers, and we're also going to have a CVP waveform and number. And then we're also going to have a motor current as well, same as our left-sided devices. But take note that your motor current on your right-sided device is going to be less pulsatile than what it is on your left-side device. We just don't have, or it's just decreased pulsatility because we're on the right side. You can see in our corner there, we have in our Impella flows, like I said, we have flows of 4 liters with the Impella RP. Also, you can see our PAPI right here is calculated as well, using our PA pressures and our CVP from our Impella device. Some special considerations whenever we're monitoring these patients. So monitor the placement signal in waveforms to detect any kind of occlusion of the device. So looking for any kind of suction alarms as well with this pump. We want to make sure we maintain positive CVP as well. So just because they have a higher CVP to start with doesn't mean we want to get them way down. We still need that preload. We want to make sure that we're reducing any kind of air that could potentially get into the system by making sure we have occlusive dressings and making sure that we have all caps on anything that's tightened, that's open. We want to chart our Impella parameters and our hemodynamics as normal. And then if CPR is required, P2, just like our left-sided device. Shocking, again, no issues there. Head of the bed, less than 30. And whenever, something also to take into consideration, we want to make sure we're maintaining this device at P6 or higher. The reasoning for that is we don't want to decrease the flows because of that lower pulsatility side on our right. That can cause some type of clots, unfortunately, to build up, and then we don't want to take that within our device and go into the PA especially. So we want to keep flows of 1.5 liters per greater or a P level of P6 or greater, unless we are actively weaning. So something else to take in, and also for positioning, we recommend a chest x-ray instead of echo for our RP, all right? That way we can visualize the whole pump underneath chest x-ray rather than underneath echo. We have to look underneath 2 different views, one to view the inlet cage and then one to view the outlet cage. So you cannot use a thermodilution calculation with the Impella RP, just related to where the Impella is and where the flows are coming out and where the thermodilution calculation will happen. It actually interrupts that cycle and it can cause an incorrect reading on your thermodilution cardiac output. So we recommend a FIC cardiac output. Now I'm never going to ask you to remember this formula, but I will say that they have MD Calc. It's an app. It's a great app. And it has any type of calculation that you can ever even think of. I know they have some as well on online as well on MD Calc. And it has the FIC formula in there, and you can just plug in all your numbers if you'd like. Whenever we're weaning this pump, like I said, the wean looks a lot different with this pump. First things first, we're going to decrease the Impella RP down to P2 momentarily. We're going to probably keep it at P2 for about 20 minutes. We're going to get an echo, look at the RV, make sure that the RV looks like it's contracting okay. If our RV looks okay, we'll go back up to the previous P level and we'll start to initiate a slower wean at that time. So ACTs are 160 to 180 for our Impella RP. I will recommend keeping it closer to that 180 range though, just to make sure that we're not going to have any kind of clots within that system. If you're going to keep the Impella at those flows of 1.5 liters per minute on the right side, make sure that we're increasing that ACT then to about 250, just to make sure that we're not going to cause any kind of clotting. And then removing the device, the physician's going to remove the old mattress suture that was placed, place a new mattress suture to help with hemostasis, and then pull the Impella device across, let a little bit of bleed back down, and tie off that mattress suture. And you guys have tons of resources with Abiomed and with Impella. You have the Impella app. If you guys don't have it, they've just recently updated. It's a great app with great videos to help guide you guys in any kind of questions you guys might have. You have the 1-800 number. Like I said, it's a 24-hour, 7-day-a-week team. It's people that were clinical consultants out in the field for, I think, like 5+ years before they were even able to go to that position. So they have seen a lot out in the field before they were able to go up to that. Also, you guys have your local team along with any type of resources that you might find underneath heartrecovery.com. Any questions? Thank you.